Okay, good afternoon, everyone, and welcome to the Natural Capitals event on Proof of Life, Where Next for Evidence Linking Nature and Health. So I'm Paula Harrison. I'm from the UK's Centre for Ecology and Hydrology, and I'm part of the Secretariat of the Natural Capital Initiative, along with Laura Bellingham from the Royal Society of Biology and Alison Hester from the James Hutton Institute. And for those of you on the call who may be less familiar with the Natural Capital Initiative and the events that we organise, we're an independent forum for bringing together science, policy and business for debate and joint working on natural capital challenges and solutions. We work to ensure that evidence from across the natural and the social sciences supports public policy and business decisions on natural capital. And we're really delighted to be hosting this really topical debate today on the current state of evidence linking nature and health. And before I introduce our chair for the event, I just have a few housekeeping notices. First, we're recording this event and all of the attendees will remain muted throughout the event. And we're really looking forward to your questions after I've handed over to the chair and the panel of talk. So please can we ask you to submit all of your questions through the Q&A box. The chat is currently closed just to avoid confusion. So please put everything into the Q&A box and that will be monitored by our chair during the discussion. We'll cover all the questions that we can in the time available. If we don't have time to cover your question, they'll still be really valuable because we'll look at them all and use them for planning future events and future activities for the Natural Capital Initiative. We're also really grateful for any feedback on this event or for suggestions for future events. So please feel free to email the Natural Capital Secretariat if you have ideas. So now I want to introduce you to Professor Dan Osborn, who's going to chair today's panel. And Dan is Professor of Human Ecology at the University College London. And there he undertakes teaching and research as part of the UCL Earth Sciences. His interests cover human well-being, ecology, and strategies and policies that affect our environment, especially in relation to climate change and coastal communities. So I'm really looking forward to hearing Dan's thoughts today as he sets the scene and he welcomes the panel and he hosts the Q&A. So I will hand over to you now, Dan.
Thank you, Paula. Well, welcome everybody to today's event, welcoming our speakers as well. I'm sure they've got quite a few interesting points to make. I'm very interested in this area of activity, how strong the evidence base is, how we can draw together, which is what's often seen as a bit of a fragmented evidence picture, because at the end of the day we've got to turn that evidence into actions of some kind, and there at that end of the scale there's quite a few gaps which we might come to in the Q&A sessions, but we thought we would focus today on how strong the evidence is and what the kinds of things we could do perhaps to make it even stronger. And I think Becca Lovell from Exeter will have quite a lot to say on that. But first of all, I wanted to perhaps introduce Professor Hugh Montgomery, who's an intensive care consultant, director of the Centre for Human Health and Performance at UCL. And he's a pioneer advocate for action on climate change. So it's interesting how the climate change community is interested in this issue of green space and health and how people interact with their environment. Quite a lot of common areas there in terms of green infrastructure and things like that. And Hugh chairs the Lancet Countdown on Climate Change and Health and has a lot of experience in bringing together different evidence and experts to make compelling arguments about managing our environment for our survival as a species on our planet, whose resources are increasingly under pressure. And we are seeing the consequences of that pressure, which in many cases we perhaps didn't realise the consequence of our actions. But now we've got to. So Hugh, over to you. Thank you very much for coming along.
Well, thanks very much for having me, Dan. And I will share screens now. So if that's going to share nicely, there we go. So I'd start by saying that I think you're right. You pointed out the action gap. I think we've got immensely strong evidence that the environment in which we live impacts our health. And we know very specifically in large domains how, or even if we don't know how, we know very specifically that specific things do, and we should address them. The problem is the action gap. I think we've got lots of evidence. The problem is how we get people to listen. And that's partly because environment, any measure of environment and health have normally been chalk and cheese. They've been viewed by many people as completely separate things. There's the environment and there's health, and the two have nothing to do with one another. You know, in one particular case, the health side, that's actually about spangly drugs like chemotherapy that make your hair fall out. And environment, well, that's something you leave to Public Health England, who a lot of people hadn't heard of before COVID and mainly dealt with diarrhea outbreaks. And that's pretty much the limit. And it wasn't so much as if the bridge between those was broken. There's a fact that no one had ever really created, in my view, an adequate bridge between an understanding that environment is everything to do with health. And of course, looking back on it, we've known this in terms of sanitation, you know, Bazalgette and the building of the sewers when the Thames was so smelly that Parliament got fed up with it. And by doing that, we essentially got rid of cholera in the City of London. We know that if you change legislation, which is environment, and you change public habit through that you get massive reductions in smoking. That stepwise drop when we banned smoking in public places, not long after we banned cigarette machines being available to sell cigarettes, and that being the major contributor to this fall in heart attacks. And the same, of course, we see we've adjusted environments to improve health and safety. So you can see the vehicle miles traveled is going up, 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 but the deaths behind the wheels of motor vehicles is going down, down, down. We've made the road environment safer. We've made the vehicles in which we sit safer if we do happen to have a crash. So the environment matters to health. None of these things were technical medical fixes at all, but actually they probably overall have had a much greater impact on survival than most of the spangly drugs we use. When we don't pay attention to the environment, then that's what we see. There's this number of school shootings going up very steadily and then very dramatically. And guess what? Gun ownership is very strongly correlated with gun deaths. If you make guns readily available, more people will use them in an argument or when they're generally cheesed off. So these environmental forcings cut both ways. But we still, whilst we've learned for the fixes like cars and cigarettes to some degree, we haven't learned in most other aspects of health. So this is avoidable cardiovascular deaths. You can produce the same sort of graphs on pie charts for cancer. But if you look at the attributable burden that's avoidable, it's nearly 8 out of 10 cardiovascular deaths would be avoidable by changes in environment, i.e. how much exercise we take, how much particulate pollution we breathe in, whether we're able to buy cigarettes and the sorts of rubbish food we eat. But we haven't connected those environmental factors very readily at all. So far from turning the tap off of patients pouring into hospitals, which we could do if we address the environmental factors, we continue to bail or to try to widen the plug hole to treat the disease cases we get more rapidly or more effectively. But it's a much, much more expensive way than turning off the tap at the top. Now, if that applies to environmental factors like cigarette smoking, alcohol consumption, and driving cars, it's only been recent that people have noticed that the planetary environment matters at all to human health. In fact, the first COP negotiations on climate change I went to in the late 2000, I think it was 2009, I was one of only 2 medical staff present at the entire negotiation. There wasn't a single mention of human health in the entire document. But we do balance atop a very teetering ecological pyramid that threatens our survival. We've noticed this a little bit only in the last year. Let's look at the crossover events from environmental degradation. As we're destroying habitats, we're forcing animals into closer and closer proximity. We're causing them to predate in ways that they wouldn't otherwise. They're forced into areas where they wouldn't meet those other animals, but also their ecologically rich networks are collapsed. Humans are pushed into those areas hugely. So as you saw with Ebola, that was largely due to humans being around the bats where they shouldn't have been in the first place. And by changing farming patterns and markets. Through all of those sorts of things, the way in which we have mistreated our environment has been leading to these spillover or crossover events from animal infections to us. So here are the mink farm, which of course were massively mutating the COVID pandemic for us, the coronavirus. Look at the birds, no great surprise when 72% of all birds on the planet are now farmed poultry, that you end up with these being basically giant petri dishes for avian flu. These are the wet markets, pangolins next to bats, next to rodents, next to dogs, next to deer, and only round the corner, these animals were alive, mixing feces, fur and feathers all together, many of these being dragged out of forests and rainforests too. And let's look at what that change in the way we treat our environment has done. We had Spanish flu, which was a wild bird flu that went into domestic birds in 1918, as we know, killed more people than the First World War did. Probably HIV first appeared from simian immunodeficiency virus in early as in 1920, actually. It's probably been with us for quite a while, but again, that was a spillover event coming from monkeys into humans because humans were mixing with monkeys when they should not have been. Then, of course, 2002, we had bat, SARS-CoV-1 spilling over into humans. 2009, we had bird virus coming via pigs to hit humans. That was H1N1. 2012, we had MERS coming from camels. 2018, we had Ebola coming from bats in the Congo. 2019, we had SARS-CoV-2. So whilst we had pretty much 100 years with only 1 or 2 spillover events, we're getting a spillover event because of the way we treat our environment every 2 to 3 years now. And then we spread them around the world. So this was the pattern of spread of SARS-CoV-2, and you'll all remember this. Everyone going, why on earth have we not stopped flying as we watch this disease being spread by air traffic around the world? And remember, this was Heathrow in 1930. It was farmland with a tiny little grass airstrip, which you could actually see if you look closely at that map. And that was Heathrow in the days before lockdown, 176 passengers a second flying worldwide, spreading the disease. So we haven't learned from that. We didn't learn then, we haven't learned now. We're encouraging everyone to get back on planes. And finally, just to close on the issues of climate change, this is atmospheric CO2 concentration for 800,000 years. That spike to the right is what we've done in the last 50 years. This was May 2018, 412 parts per million. 1st of May this year, 419 parts per million. And so this graph is still going up pretty much vertically. We're adding 5 Hiroshima bombs of energy to our atmosphere a second. So the climate change from the gases we've added the equivalent of 2.8 billion Hiroshima bombs of energy into our atmosphere since 1998. That's energy that's still there. And if you add energy to an atmosphere, you get weather. We're getting sea level rise from ice melt and thermal expansion, threatening, as we've seen from this paper only last year, huge, huge numbers of people, even with that relatively small, steady rise of 1 centimetre every 2 years in sea level. But sea level will erode land, which will drop into it. People move long before they're underwater, and this rate of change is unlikely to remain this low. We've had these extreme weather events, this documented by Carbon Brief. You'll see of all the recent extreme weather events, far the majority are statistically attributable to climate change. This was Australia, the weeks before COVID hit us. Remember, we'd got nearly 100,000 square kilometres of vegetation had burned. Koalas essentially functionally extinct. But this was happening all around the world. The subterranean fire burning its way through peat in Siberia starting in 2019 has now affected an area the size of Belgium only a year later. That was by 2020. We've got the same fires, hearing about that today in the news. The Amazon now being a net contributor to greenhouse gas emissions because so much of it is ablaze. We've got the same in Angola and Central Africa. We've got the same in Indonesia and South America. We've got the same in California. And of course, we've also got the same in Canada now. All around the world is ablaze. And that's not talking about the extreme cyclones, typhoons, the extreme rainfall, strong winds, and so forth. And all of these things we know, and we've been mapping these for at least a decade, impact on human health. Climate change affects pollen allergenicity, burden, spring length, spring season, and so forth, with granular level ozone and heat waves causing fires and particulates. You end up with respiratory disease. You get cardiovascular disease. You end up with flooding, droughts, reduced physical work capacity. With ecosystem collapse, you end up with loss of crops and starvation. You've got algal blooms in the bottom left there with bacterial disease causing chemical poisonings as well as diarrhea. You've got huge changes in vector-borne disease, which you could predict and which you can measure. And together with loss of habitation, poverty, starvation, you get mass migration and war. These things were all predictable. They were predicted. They have all happened. They are all getting worse. The evidence is absolutely crystal clear. The Pentagon was warning about this in 2003, the risk of significant drop in the human carrying capacity of the Earth's environment. That was 18 years ago. We've been documenting this in the Lancet Countdown for 5 years. As I commented before, I wonder if we're just documenting our own extinction, because every year we produce the evidence of what we're doing, how much worse it's getting, how much worse the predictions are, and every year absolutely nothing at all happens to make a difference. We're now on the worst case track of emissions, that's RCP 8.5. That takes us really to the end of human civilization, or us as a species, in the matter of decades, 100 years or so, rather than longer than that. We now know, as of the paper of June the 18th, that we're now into the positive feedback loop for loss of ice. Energy gain has doubled in the last 14 years. We've got positive feedback from melting methane hydrates. You've heard today, we've now got positive feedback from drying out and fires happening in the Amazon, adding more. And all of that is happening on the top of the fact we've destroyed ecosystems to the extent, even without climate change, that 8 species now are becoming extinct. And we've killed off 70% of all vertebrates on the planet in the last 50 years alone. The statement from the leaked UNFCCC report, from the science report that got leaked a few weeks ago, what they're saying, they've got the clear evidence: species extinction, widespread disease, unlivable heat, ecosystem collapse, and cities menaced by rising seas will become painfully obvious before a child born today turns 30. We've been saying this for 20-something years. It is obvious and known, proven, measured every single year, but we do nothing. Finally, then, what do we need to do? Well, we decarbonize the world's economy for 2.38 trillion a year, which is only 2.5% of global domestic product. That's all that's required. It's not a lot. That's what we spent on COVID last year alone, $11.7 trillion. And the US alone this year is committed to a stimulus package for COVID of nearly $2 trillion. Pretty much everything that would have been needed to decarbonize the world's economy if spent this year. And yet, when we ask for money into the Green Fund in the climate for the COP negotiations, that's been 100 billion asked, and that's been going on for 5 years. So far, there's only 8 billion in contributions in it. So that's where I'm going to end my talk. And this was on the back of in 2019, one of the youth delegates. You've been negotiating all my life. You cannot tell me you need time, because this is an issue of intergenerational equity. It's what you and I as adults are doing to the next generation and that we have no right to do. So to close then, I take you back to the comment that was made at the beginning. The question for me is not what evidence do we need to convince politicians that the environment matters to public health. The question is, how do we use the evidence we've already got to get the change in society, business, and politics that we actually need to take place and that we've yet failed to deliver? Thank you for listening.
Lovely, thank you, Hugh. We'll get some questions as the meeting goes on from people. So I think we'll take those more towards the end. I know you have to go at a certain point, Hugh, but we'll see what we can do on that. But thank you for setting the scene so well and clearly for us. So let's now move on to Becca Lovell. She's a research fellow at the European Centre for Environment and Human Health, looking at health and well-being benefits of higher quality and a more biodiverse spaces for I suppose for species as well as people. She's in particular for this meeting, she's the author of some pretty large-scale reports using qualitative and quantitative methods to develop management recommendations for DEFRA and for the WHO. So this is, Becca's work is very much about how we start to manage some of the situations, some aspects of the situations that Hugh's talked about, but I imagine we may still have a question after Becca's talk about these action points. Let's see how we go. So over to you, Becca. Thank you very much. You're already sharing your screen, I think.
Perfect, thank you. And apologies, my internet does hang a little bit at the moment. Our infrastructure is a bit poor down here in Cornwall, but thank you hugely for having me come speak today. I was lucky enough to speak at the original Proof of Life meeting when I covered some of this material, so I'm going to sort of move us on a bit and just reflect where we've got to and where we might need to go. I'm going to shift gear a little bit from Hugh's brilliant but devastating talk and talk a little bit more sort of domestically and about how we use nature to promote health here in the UK. So since I spoke in a few years ago, we have continued to very slowly, at a snail's pace, build the evidence base. And I've just stuck up some images from some of the reports that we've been working on, which seek to summarize some of this evidence for different audiences, whether it's WHO speaking to nation states, and particularly government departments which don't think about this, through to Public Health England and DEFRA and so on. And I think one of the things I was asked to speak about today was who needs to be at the table and what agencies and departments and so on need to be part of this. I'll just carry on. We have been slowly building the evidence base, looking at how different bodies of evidence can be used to think more about how we use the environment or think about managing the environment for health outcomes. And we've demonstrated with this body of evidence that there are fundamental complex linkages between the places in which we live, work and play and our health outcomes. And what's been happening recently in the last few years really is that we've started to show how nature can be thought of as a significant potential as a tool or setting for health promotion. And this is primarily through what we've now started to call green social prescribing, so sort of therapeutic use of the environment. And that evidence is growing in its robustness and also its scale. So we've got a good idea of the different types of linkages and some idea of how they play for different communities and different health outcomes and so on. And in terms of green social prescribing, we are getting a much better understanding of how activities which we've run for many years of taking groups of people out into nature as a way of promoting their health works. But what we're interested in now is how the system around that can be improved. These activities don't happen in isolation. There are an awful lot of different aspects to this. So we're beginning to understand how different actors and different processes and mechanisms and resources and so on can be brought to using the environment to improve some of our sort of wicked problems that we have in public health at the moment. However, I did say that our evidence base has grown. We still have huge gaps. And I think this speaks to some of the questions which Hugh was beginning to raise, is that we know how nature relates to health, but actually instrumentalizing that at a more local level is problematic. And what we don't know is what is good or good enough when we're thinking about infrastructure for health and wellbeing outcomes. And this is a challenge at the moment for our planning systems. And in terms of green social prescribing, it's still a key priority is that we work more to improve understanding of what works, how and for whom. We don't know what types of green social prescribing are most appropriate for different mental health outcomes, for instance. And this leads us to the other version of that model I just showed you before when we're thinking about green social prescribing systems, for instance. The blue version is a sort of idealized system where I've identified the different resources and capacities and processes that need to be in place for that to work. What we've tried to do with this model is illustrate the many numerous fail points. Green prescribing is a relatively new system. The activities have been around for a long time. And I think as we start to see this play out, we'll start to understand how we need to work on different parts of this to understand how to better use this resource. One of our key questions is how to identify mechanisms which facilitate coordination of supply and demand this model here. One of the things which we think is going on is that social prescribing both adds to system pressures and system level sort of interactions being put in place. So we see that social prescribing can add to system pressures, but you also find that there isn't a systematic of these kind of interventions meets the demands that are coming from the system. But we're also seeing pressures on the providers. So both in terms of the use of environment, we're seeing greater pressure on environments, sensitive environments quite often, but also pressure on the bodies which have been expected to provide these activities. So predominantly third sector, natural environment, charities and so on. So what we think now is not so much about producing the evidence of demonstrating the effect of
Becky, your sound has gone again, unfortunately.
Sorry.
Right, can't help it.
Sorry. So it's about understanding the systems, but also trying to understand what are those factors which will facilitate. So understanding the values that will matter. So it's not just about putting a value on nature, it's a value on the different types of outcomes.
So hoping we'll get Becca back in due course, but I think we should perhaps move on and come back to Becca if that's possible at the end. So thanks, Becca, for that, and nice to see how that dovetails and links to Hugh's earlier presentation, where showing those areas where environment and health are quite clearly and closely linked, and Becca's two slides, the blue and the red, on the way the system is working at the moment, and some of it, of the new aspects of it, such as the social prescribing side, perhaps adding to a little bit of the system complexity there. So let's move on for now. Do use the Q&A to put your questions in, but let's move on to Dr. Michelle Howarth now. She is a senior lecturer in nursing at the University of Salford, and has a specialist interest in social prescribing and the use of nature-based, person-centered approaches to promote health and well-being. So it's very much, I think, at that action end. And she leads the National the National Social Prescribing Network Special Interest Group for Nursing. So, Michelle, have you got some slides to share with us, or are you avoiding slides?
No, I do, Dan. A good academic needs to keep on track, and I think we're one of those.
Over to you.
So, can I just check you can see my slide there, the first one?
Yeah, that's fine. Proof for life, methodological challenges, etc.
Brilliant, thank you. So I guess I'll probably, when I was listening to Becca then, I was thinking, well, a lot of the stuff that I want to talk about builds on and completely concurs with what Becca's been saying here, particularly about the evidence base. So, thank you so much for inviting me here today. And I really want to discuss how we link the evidence base between nature and health, but really get to the grips with the methodological issues that might have created some challenges to that gap that Hugh was talking about earlier on. And in particular, I wanted to take this opportunity to explore how different types of evidence have influenced, in particular, clinical decision making, and the way in which this might be interpreted through our evidence-based paradigms that are used by professional regulatory bodies that govern medicine, nursing, and allied health professionals. And I also wanted to focus on green social prescribing, which Becky alluded to then, and how evidence can be used to support the use of nature as a health intervention. So arguably the action gap referred to by Hugh could be partly addressed through convincing our policymakers and commissioners, and by those who make all the clinical decisions, to value nature and to use nature a bit more as part of a wider social prescription. It was interesting that yesterday I was at a meeting at Greater Manchester where we were talking about social prescription. So in Greater Manchester we have over 17,000 VCSE organisations that basically operate that third sector, that provide a lot of the social prescriptions, and a small percentage of those will be offering nature-based solutions. And that we had the discussion yesterday about how do you convince people the money doesn't follow the patient? How do we convince GPs, practitioners that nature and prescribing nature is actually good? And some of that is down to, I think, some of the methodological issues certainly that we've uncovered with our research as well. So I'm hoping that this next 10 minutes might give you a little bit of insight into those thoughts. So social prescribing as defined here, and the reason I come to this is because it's really important we understand that this is a personalised approach. So it's the process that enables a frontline practitioner, so that could be a doctor, nurse, or equivalent, to refer patients who have a non-clinical need to a link worker or equivalent. And that link worker has a wellbeing conversation with that individual to ascertain what matters to them rather than what's the matter with them, so that they can co-create these personalised non-medical solutions. And those non-medical solutions can be anything from yoga, knitting groups, through to more structured therapeutic activities. And as Becca was alluding to, green social prescribing, which is fairly not new, but there's a lot of interest in it at the minute, follows the same process. But obviously the non-medical solution will be a nature-based offer, such as an allotment group, walking outdoors, structured programme of therapeutic horticulture. And we know over the years, and again, eloquently put by Becca, but at snail's pace, this evidence base is growing for the use of nature to support well-being. And yet, despite centuries of recognition and appreciation, we've only recently started to explore the impact of nature and well-being with any degree of scientific rigour. So in the mid-80s, when I was training as a student nurse, Roger Ulrich, who's an American researcher, undertook that famous study examining the impact of a view of patients post-operatively following cholecystectomy, so removal of gallbladder. And he compared the recovery records of 23 matched pairs of surgical patients, with half the patients in the room with a view of a window over trees, and the other half in an identical room, but the window looked on a brick wall. And his results unsurprisingly show that those patients with a view of the brick wall spent less time in hospital post-op, were more positive about their progress, took fewer analgesics, compared with the ones who had a view of a brick wall. So granted, this was a very small sample size, but other researchers since highlighted the benefits to having a view, participation, and being in nature. And Jules Pretty's work is excellent in demonstrating this. And we also know that a lack of access to nature and green spaces can impact on younger people. We know, and particularly during the COVID era, children spending less time outdoors, have limited access to nature, and they could suffer from what's known as nature deficit disorder, which could lead to a wide range of behavioural problems. So we know that nature can reduce depression, anxiety, improve mood, increase longevity, energy, reduce symptoms associated with ADHD, trauma, psychosis, addiction. It can improve our quality of life, and for those suffering from Alzheimer's. And finally, not least, it can improve relationships, increase sense of gratitude. The list is pretty much endless, but the evidence base isn't strong in terms of its methodology. So this is a bit of what I wanted to highlight to you. Sorry, that picture's a little bit fuzzy on screen. Clinicians are influenced professionally by an accepted hierarchy of evidence for effectiveness. And that's an example of one of many iterations of it. And the top of the hierarchy includes the evidence that's predicated on a very positivist paradigm. It explores cause and effect, it aims to understand what works for who, to be able to generalise to a wider population. So evidence such as randomised controlled trials that manipulate variables, control, limit bias, randomisation and blinding, employ powerful statistical analyses that try to account for the likelihood of something happening by chance. This type of evidence convinces clinicians and practitioners that the treatments they prescribe are safe and effective. So this kind of pathogenic model that focuses on cause and effect sort of pervades our policies, it influences NICE, it guides our commissioning processes. And it's based on the need to understand the cause of disease so we can create effective treatments. And we've kind of diluted the human being through medical cosmology into a world that looks at humans on a cellular level. And Foucault in 1963 referred to this as the medical gaze. So we've mapped the genome, we know what the DNA structure looks like, and we can measure the impact of our healthcare interventions. We know what vaccines work, just about, against COVID-19, for which age group and which variant, and we know through experimental studies, all of which are really valuable. And they can also help us understand the impact of nature on our physiological outcomes, such as stress, blood pressure, heart rate variability, all the sorts of things that cause long-term conditions. And this is really important, but experimental approaches don't tell us what it's like to be human. or the frailties in human nature that cause us to be ill in the first place. And they also might not be able to tell us why some nature-based interventions work and others don't, why some people take up a green social prescription offer and others don't. And the more subjective mental and spiritual and emotional outcomes that are really difficult to measure are the outcomes that are really important when we look at nature-based interventions, particularly for those people with mild to moderate mental health problems. And we can see at the bottom of the hierarchy is more qualitative data that seeks to understand experience, to generate meaning about a phenomena, what it's like to live with a long-term condition, what makes things worse, what helps. And there's no attempt to manipulate control. The research is part of the process and bias is treated very differently. There are no predictions, no cause and effect, but you can't generalize from this type of research. And yet this qualitative research is the bit that really helps us to understand what works and why. Ironically, the personalised approaches used in social prescribing and nature-based solutions means that there's no standard approaches or outcome measures that are used to capture the impact on well-being. People describe nature in very different ways. There are many different interpretations of what it means. A nature-based solution could involve gardening through to planting a seed, digging a hole, growing veg, merely taking in a vista or walking in nature. Ontologically, therefore, you could argue that people with experience nature in very different ways. Others, therefore, have noticed this, others also have noticed this, commented that even our previous experience of nature as we're growing up can influence our later reactions and behaviour to the natural environment. So it becomes really challenging to conduct experimental studies and produce evidence that fits with this kind of hierarchy. And it's this type of evidence that's needed to convince some clinicians. Take, for example, the recent evaluation we did of the RHS Bridgewater Wellbeing Gardening Programme. The results from that were brilliant. They clearly highlighted that this had saved a lot of people from being stuck at home. It got them outdoors, it reduced social isolation, it reduced their depression. And one of the biggest challenges for that social prescription was convincing some of the GPs to make the prescription in the first instance. So there is interest in green social prescribing, and we recently published a scoping review in the British Medical Journal last year, in which we reviewed over 8,000 papers, and we produced a logic model to sort of help guide clinicians and commissioners. And the reason why I mention this today is because since its publication in July 2020, the full paper's been downloaded over 9,000 times, picked up by 14 news outlets. And we've had many different emails. I had an email today from a student nurse, another university, that had read the paper and was so convinced by the evidence base and really wants to take social prescribing forward, and argues, why aren't we being taught this? Why in nurse education, which is another different soapbox I'll get onto on another day, why are we continuing to learn and operate a very medical model with our placements? But there are still research challenges associated with evidence base, and many of the data collection tools that we observed and we have used capture that subjective self-report of well-being, such as SwimWebs or Recovery Star. And that lack of standardised tools has led to an inability to pool the data, creating a kind of limited evidence base. So that particular paper highlighted the methodological challenges, and in particular, the lack of a clear population. And if you think about green social prescribing in particular, it can improve well-being from anyone from cradle to grave. There is a lack of a definition around gardens and gardening. We use Book's definition from the King's Fund Institute for that particular paper. And so thus there might be limited systematic reviews because of those inabilities. But there is lots of qualitative evidence. And whilst there's no intention to explicate cause and effect, the evidence base does highlight the power of nature to heal, change lives, and in some cases save lives. So hence the DEFRA work that Beck is involved with and the green social prescribing evaluation will be really interesting, as we might start to get a better understanding about what type of data works, and what works for which people, and what's meaningful data for practitioners and commissioners as well. So, however, there is a need to understand that the research should be population-led, and to understand people and communities as part of that. And we need to avoid the pitfalls of just using data, just as GP attendance for all outcomes. For example, not all green social prescriptions are there to help reduce inappropriate GP attendance. And for those people with long-term conditions, you certainly won't see a reduction in hospital episode data. But to do this, maybe the first step is to challenge our assumptions about health, adjust our methodologies so that we can capture meaningful data that tells the full story about the impacts of nature on well-being. We need to triangulate our data to strengthen and convince clinicians and commissioners, and use the quantitative evidence to determine the physiological impacts such as stress, reduced cortisol, combined with the qualitative subjective outcomes that describe the experience. However, this doesn't really account for the inability to compare like with like, and therefore reduces our opportunity to generalise to a wider population. So maybe we need a halfway point and agree outcomes that be measured and pooled. And importantly, this proof of life debate presents a significant opportunity to explore these challenges, question our assumptions, and address those methodological imbalances. And I look forward to discussing this more with the panel. Thanks very much for your time.
Michelle, thank you very much for your presentation, and particularly perhaps the last point about common measures, etc. Something perhaps I can ask the panel about to comment on a bit more. Those kinds of commonality, I think, are quite good. Just a reminder to everybody to use the Q&A for putting some questions. We've had one request about the BMJ paper, and I think that's kind of been answered already live. I think someone's dealt with that already. Certainly a useful piece of work, and there are a few reviews like this now coming out. They're not always easy to deal with if you're reviewing them, but I think it's nice to see that kind of thing is there, and perhaps that will help us raise the standard of or raise the perception of the standard of the kind of evidence there is. And I think Becca Lovell's red and blue diagram, I think, really quite interesting to look at those and to see where those red areas are highlighted within this rather complex landscape. But I imagine that Hugh is in clinical practice is quite used to having to negotiate an effective path through that kind of complexity. So I think we could move over now to the panel discussion, and maybe I could start by asking a question that actually somebody sent through to us earlier. So to what extent is the growing body of evidence linking nature and health accessible to decision makers, and if it isn't, what might need to change to make it more accessible? Hugh, do you want to say anything about that at all?
Yes, I would say most data on any subject are inaccessible to policymakers, at least to politicians. That's because once they're in power, they spend their entire life bouncing between Radio 4 Today programme and Daily Mail headlines, cabinet briefings, etc., etc. The time to actually spend to interrogate and weigh the science or the evidence put before them is virtually zero. I'd go further, though. I think the other problem is not accessibility, it's inability to comprehend. So there's pretty much no one in the cabinet with a science degree, and comprehending science would be difficult. So the accessibility has to be through advisors, if one could get access to them, who have slightly more bandwidth, and producing comprehensive but short briefing notes, because again, it's a time limit problem. So yeah, it's comprehensibility as much as it's accessibility, I think.
Okay, so maybe we need some really good briefing notes, given all the stuff that Becca's done in detail. Maybe there's a case for having that boiled down in some way.
Yeah, and bear in mind, of course,
notes and things.
And bear in mind, as I said before, I mean, we've had pretty much 30 years of COP negotiations now, and UNFCCC reports are massive scientific digests, and that's been made readily available and accessible and comprehensible, and it still hasn't driven any change at all. So it brings us back to that point that you made at the very beginning, Dan, about the action gap. What do you have to do to get a politician or business to actually do anything, even when you give them evidence? And it doesn't seem to be that evidence makes much difference, largely.
Okay, Michelle, you've given us your thing there with your 9,000 downloads. Did you see any action coming out of your things? I mean, I think the garden area, the horticulture area, is something really that people can get to grips with. I mean, there was a study I know of called GROW, run out of the Brighton area, and Brighton University looked at that. That was a horticultural based activity, which had a very strong treatment effect. So maybe in that controlled environment, do you think, you know, action is easier because it's more of a controlled environment?
I think I'm sort of leaning to what I agree with Hugh, and you know, even though our paper was downloaded so many times, there's only if the infrastructure, and I also come back to Becca's work, if the infrastructure is not there. I sometimes think it doesn't matter what the strength of the evidence is, if you've not got the infrastructure to support it in the first instance, if you've not got policymakers being able to understand it, because everyone can access evidence. You know, it's about making the time and prioritising it. And those people who advise our policymakers, you know, it's about their understanding of the significance and where we place this priority. And at a sort of a grassroots level, you know, the work that we've done with a few nature-based organisations locally, the evidence base for us is strong, but getting that joined up thinking, getting the infrastructure to support that, getting clinicians engaged with that is a whole different ballgame. And I think unless we've addressed that, unless we've addressed the infrastructure support, we're going to really struggle with actually gaining momentum with the nature-based solution approach and green social prescribing in particular.
Okay, fine. Thank you very much. Does anybody else on the panel want to comment on that at all? No, I don't see that. There's an interesting question from Andrew Planet, who aptly named. Do you think the reason we need nature to feel healthy is because human physiology has evolved in response to and in the context of other organisms in our environment? And I'd add to that myself. It's not only the other organisms, it's the physical nature of the environment. Very often we think of the environment as the biodiversity, but it's all the physical stuff as well, which has generated, exploited to generate our wealth in many ways. So Andrew's asking about that, and he says there's even a term for this, which is evolutionary adaptiveness. So I think potentially this is really an interesting area, because it's a way of thinking about the mechanisms by which nature delivers, you know, well-being benefits, etc. Hugh, do you want to chip in here?
I couldn't agree more. I mean, I think the evidence, as you say, Dan, as the person who put the question, is growing. I've had a few students who couldn't do lab experiments doing library work in the last year, and I've had a few of them focusing on microbiomes, all the flavour of the month. Of course, humans only started applying soap and detergent to bits of their skin that weren't the visible parts, like their face and hands, in relatively recent decades. And if you look at the genome sequences of the bugs that you otherwise find on skin, they've been with humans since humans were early hominids. I mean, they contain large sections of human genome. They've been there living symbiotically with us for a long time. And yet we've decided in the last 50 years that we're going to exterminate them with soap and detergent. They're symbiotes. They clearly got a good home from us with all sorts of nice nutrients and things from our skin. And there's good evidence they give us things back, not least of which is their antiviral properties. But also, if you look at the ammonia metabolizing organisms, the breaking down of ammonia that would otherwise make us smelly to yield large quantities of nitric oxide, the benefit of which we don't yet know. So yeah, I think it's yet another example of our idea that we have to divorce ourselves from the natural world to remain healthy, when the opposite is true.
Okay, thank you. Becca, do you want to add anything to that? I think Becca's screen is frozen. Okay, let me just maybe add to that myself. I mean, I do think the physiological basis of these things is interesting, and I think back to Michelle's point about some agreed measures that we could help to strengthen things in a particular area. I was recently involved in reviewing some of the mechanisms that might be associated with culture-based interventions and nature-based interventions. And I think, I mean, I can't remember exact numbers, but there was well over 100, maybe more than 200 different measures that different laboratories had used at different times and places in different kinds of studies, to try and get some handle on the mechanisms for this, to provide perhaps some more convincing ways of arguing for the benefits involved. But with so many different measures, it was almost as if the labs were measuring what they would measure anyway, as if there hadn't been, the community hasn't got a handle on these physiological response sufficiently, but there is bound to be one, and we just need to sit down perhaps and decide what those things should be. So that may be something as a takeaway from the meeting that we can make use of. So maybe if Laura or Harriet are making a note here, I mean, that's the kind of thing perhaps we could have a look at. I'm going back to some questions, quite a few coming in now. Penny Shimin from the Sussex Community Development Association, hello Penny, says, how can we bring the community development side of things into this debate? We've talked a bit about social prescribing, etc. Penny says there's a need to link green groups, which there are great numbers these days, and health with practical implementation and community engagement. Understand what the barriers are, what funding and sustained funding is required to achieve action and joined up thinking. Michelle, I mean, you're close to the coalface here in communities, I'm sure. Do you want to comment on Penny's points at all?
Yeah, I think if we could provide a reliable map of what nature-based interventions are going on across within the sort of the social prescribing world, that would be absolutely fantastic. I hate to put challenges there, but a couple of years ago we mapped the extent of social prescribing just across Greater Manchester alone. And given that we know there's only 17,000 VCSE organisations out there, we probably only captured about a tenth of that. And from that tenth, there's probably only 2% that were actually nature-based interventions. And the problem you have is out of those 17,000 organisations, which is sort of typical of your community sector, 71 to 72% of those are micro-organisations that bring in less than £1,000. So they're here one minute, gone the next. So an example that I worked with a number of years ago, which was part of the Incredible Edible campaign, was Green and Growing Project, which was a small allotment in the middle of a really deprived area. And the director there, Ian Bowcott, worked fantastically well with local schools, with the local college, with the community. But you know, he absolutely struggles year on year to get the funding to support that. He doesn't receive core funding, and a lot of these organisations really struggle. And because of that, they're not there year on year. So that face of the community sector is moving each year. And so it's hard really to pinpoint exactly what's going on. Unless you've got big organisations like the RHS Bridgewater, as you know, suddenly arrived in Salford, which is fantastic. Unless you've got the huge organisations, the National Trusts, it's very difficult to isolate the actual green social prescriptions that are going on with the smaller organisations, those micro and small groups, which I think Becca's work is going to start to unpack a bit more. So if you can map it, it would be fantastic, but it'd be a bit like nailing a jelly to a wall at the minute.
Okay, and I think Becca will want to say something on that. I mean, I do agree that a lot of the groups are very small, they're temporary. I think the problem is they're often attracting funding to do some of this thing, but it's short-term funding and they do really good stuff, but it's all at a pilot scale. So we need to try and find a way of capturing that. Now, this was done in nature conservation. Bill Sutherland in Cambridge has actually got a journal running now as a result of beginning, you know, offering the community, you know, the scientific community, the conservation community, somewhere where they could put their individual case studies. Gradually he got a standardized format for that. And there's now a journal that publishes some of this stuff. And this proved to be really convincing kinds of evidence, a presentational format that land managers could use. And so they had something there which was nearly a tool, but I mustn't exploit my chair's position too much. Becca, did you want to say anything about this community point?
Yeah, firstly, apologies for my very, very poor internet connection and stilted delivery of the first bit. But yeah, I think there are lots of ways in which we could address some of these issues, and part of it's about commissioning systems. some alternative approaches to commissioning VCSO groups and so on from the centralised healthcare system have been trialled. I think Wiltshire, for one, has had a go at it. But it's addressing some of those perverse systems that I think that we need to have a go at. I think the evidence is beginning to be there about what to do and when and for whom, and the kind of values and the kind of impact it could have within systems. Our challenge now is to address how those decisions are made and how funds flow. And I think addressing some of these cross-sectoral flow issues is one of the really important things that we could do next. Of the issue is held by one department, but the resource which could help tackle it is held by another one, and how we create systems which make it a rational thing for DEFRA to address health, for instance, health promotion and public health. And it's there, we see it a bit with the Environment Agency and some of its activities, but it's not there for other types of health challenge that we have. And I think we have to think as a system, we've got to stop addressing these as small siloed issues. And what I was going to finally say when I was talking at the start was that we are beginning to see some moves forward. So the shared outcomes framework from the government is an example of the government attempting to look at what the different departments are doing and how they could have shared ambitions, and once they recognise their ambitions, start to build those systems which could address some of these societal issues that we have with some of the societal resources that we have.
Thank you, Becca. And I think also in the community side, it's important perhaps to remember that not everything will come through a medical source. Some will come through social care or community sources. People will refer themselves into systems depending on circumstances in different parts of the country. Some people will be able to work with their health and well-being board, but a lot of people need a lot of hand-holding. So we need to bear that in mind when we're talking about action. The large percentage of the population that cannot just act if you give them an information leaflet. So let me move on to something else. Hugh, I know you've got to go. One quick thing for you, perhaps, Hugh. What about training of clinicians? Is there anything that could be done in this area? I know that clinicians are always complaining that their training is packed enough already. Are there different standards of evidence, etc., in that, or how do clinicians approach this kind of thing?
Well, you're quite right. It has been left out. We did have a course when I was at medical school in the early 80s, late 70s, called Health and Environment, and it was mainly toxicology and so forth. But there's a real demand for this to appear now. The younger generation, quite rightly, are expecting this to come in. And you're right, something has to give. And there's an awful lot of stuff to learn in high-tech medicine. But it is getting there. UCL, as you know, does include it in courses now. I talk a great deal in the first and second year on climate change and more global environmental health impacts. So there is a willingness and a wish to know this. And I certainly think it's important. I think we do need to put an emphasis on this issue of environment and make that into a public health issue, because quite simply, health services cannot sustain the model that we've currently got of trying to fix the disease. We've got more and more old people with more and more complex disease, with more and more we can do, and economies cannot support that anymore. We have to stop the disease in the first place. And that does mean addressing things like access to green space and blue space for mental and physical health, and access to environments that are healthy, not ones that are unhealthy in terms of breathing particulates and so forth. And that really does need to get embedded far more, I think. We do need a bigger emphasis on public health in a way that's not been envisaged before, and that's environmental health with a large E.
Okay, so
you're right,
yeah.
I didn't have to jump. But.
So that's how people could help prevent problems arising.
Absolutely.
Yeah.
I mean, if you look at my own world of intensive care, I mean, I keep trying to persuade Andy Haynes to do the study, but I'm pretty confident that if you were to remove environmental causes of disease, you'd shut 14 out of 15 beds, and each of them cost £3,000 a day out with COVID. If you addressed inequity and poverty and sedentary lifestyles and poor diets and particulate pollution and noise and emotional stress and lack of access to green space and so forth, that would get rid of an awful lot of the drugs and the alcohol and the trauma and all these other things that come in as well, and the obesity and the diabetes, etc., etc. I'm fairly confident you would shut vastly the majority of the beds.
Yeah, lovely, thank you. Michelle, you wanted to say something?
Yeah, it's something that we've been looking at nationally. So, for example, I think some of the key to getting people to think a little bit differently around particularly nature-based solutions or social prescribing generally is to start understanding what we're training our clinicians to do. So in nursing, for example, 50% of our curriculum is in practice. It's regulated by the Nursing Midwifery Council, and yet we invariably send our student nurses out to NHS wards that invariably fix people. There's no real push or drive to send them out to third sector organisations to work with about the number of different organisations or link workers where they can understand the wider determinants of health and what brings people into hospital in the first instance, and to try and understand how they can help prevent. Though we don't really teach public health anymore, we don't teach environmental health. So I think there's a real need for educationalists, for medical schools, nursing schools, HP, to really think about what we expose our students to, so that they can help support and deliver a message around public health and prevention, to try and sort of put the brakes on this a little bit. Because as Hugh said, we can't keep fixing people. We have to do something at a community level to try and understand what makes people ill in the first place, and using nature as a potential solution to support that as well.
Thank you, Michelle. Anyone else want to come in on that one? No. Okay, well, thanks, Jess of City for Trees there, Jessica Thompson. Sheila Haymans from the European Marine Board is pointing out a few things in the Q&A about some work that's been done in oceans and the human. One of Becca's colleagues down in the southwest, Laura Fleming, and I think we can put some of this material that's in here about the links between human health and ocean health. I mean, there's quite an international move in linking these kinds of things together, linking planetary health and human health, or the One Health initiative that runs between the Convention on Biodiversity and the WHO, where Christina Romanelli is often the secretary of those groups and has produced some very authoritative reports in those areas. And I'm sure we can circulate to everybody some of these materials that people are pointing to in the chat, including things on physiological responses and things of that kind that are coming through. I think these are for our information and circulation rather than questions. So a question then from Stuart Ayres, are the devolved nations handling this differently? Wales has specific legislation that should support this agenda. It's unclear if it's making a difference. Again, it's this action point. Does anybody want to comment on the devolved? I mean, there's more and more difference between England and the other administrations. We've very much got a sort of federal model, but with legislation in Scotland and Wales running ahead of the UK-wide legislation quite often in some of these areas, and England playing catch-up if the government's so minded. So anybody know anything in detail about the devolved administrations? Becca, do you know anything in particular for your stuff in DEFRA?
I'll try. Yes, Wales particularly has run ahead of the rest of us with its Future Generations Act, which seeks to embed that cross-sectoral, forward-looking, horizon-scanning approach. And they have a system and a structure through which decisions can be made. I think they're called the public service boards, and they meet locally and they address questions which might have an impact on the well-being of future generations, for instance. So the like the road down in South Wales, the new M4 link road, was one of those kind of decisions where they brought health, they brought environment, they brought social services and so on together to address this question. I think there's ongoing work about the effectiveness of this, and there are certainly ambitions to use different types of data to look at how this is playing out, both in the types of decisions that are being made and who's involved in those decisions, but also the longer term outcomes. I think it's only been around for about 6 years or so, so we don't really know how it's going to play out, in the kind of health outcomes that we're interested in, which often take lifetimes to manifest. And Scotland has its own sort of differences from the other nations, but I think when I think about this, the scale of Wales and Scotland, Northern Ireland, for instance, is very different to England. The proximity between the different departments, for instance, in the Welsh government, is very different to how the English government works. So I think, yes, there are differences, and I think, yes, they facilitate different types of decision making, but it's again of that sort of, with questions of scale and resources and capacities between different types of systems that we see some of these differences, and then also how they play out in different types of health outcomes.
Okay, thank you very much. Nobody else has anything on that one. I've got one here from Tony Leach, Parks for London. Hello, Tony. Nice to see you on the meeting. Tony talks about infrastructure being needed and in a sense, networks for social prescribing or for grassroots organisations to healthcare workers, etc., to use. And if these could be built up, can that kind of thing be an effective way forward? We've lost Hugh. You can imagine there's a lot of pressures on Hugh's time at the moment with COVID, etc. But Michelle, have you experience of the local networks in your area of experience?
Yeah, so I guess the strength and the Achilles heel of social prescribing, whether it's green social prescribing or normal social prescribing, is the fact there's lots of different models. And the different models means that it's operated slightly differently. So you have a light signposting type model, which is where someone might turn up to a GP surgery before COVID, obviously, regularly, and the receptionist might go, you seem a bit lonely, why don't you just pop down to the knit and natter group? And right the way through to a medium type of social prescribing, and this is Richard Kimberley's work I'm talking about now, where there's a conversation with an individual, and it might be that they might be suffering from obesity and the clinician might prescribe a gym or Weight Watchers or something. Right the way through to a holistic model, which is what we try and operate in Greater Manchester, which is around the link worker model, which can either come through the primary care networks, through link workers employed through the primary care networks, or through social prescribing schemes specifically aligned to them, or through the voluntary sector as well. And so what you have is, with a more holistic model, the wellbeing conversation, the follow-up, the working with that individual to make sure that the intervention that's been selected is actually the right one for them. So of course, with that, you've got multiple referral pathways, multiple models, which then kind of exacerbates the challenges around outcome measures as well. So the need to sort of pin that down and look at, okay, well, which model's being operationalized, what the specific outcomes for that particular population becomes a little bit more challenging. So those networks, they are there, and the organisations do talk to each other. I know Jess is one of my PhD students from City of Trees, and she's working really well with the RHS. There's a lot of outreach work going on, but actually defining one, standardising it, or expanding the networks to understand where they are and what they do, again, just becomes a little bit difficult because of the complex layers that are part of and bound into that social prescribing system.
Yeah, and I think on that kind of local issue, down in Sussex, where I live, the local nature partnership is doing quite a lot to act as a focal point of a network of some of the larger environment organisations, including some of the coastal ones and things like that. It's got a natural capital emphasis. It's got an investment strategy for that. So it's tending to to attract attention from the right kinds of bodies. But what I'm finding is that that still hasn't cracked the action problem. You know, so we can present quite a lot of the evidence, and I think Becca's reports to DEFRA and things recently are going to help with all that quite a lot. And your work, like you've described yourself in your own group, Michelle. So I think we're heading in the right direction, but we have this very complicated landscape with the you know, some issues around the dynamics of that Becca's red and blue diagram you know, highlight, you know, rather nicely. I think that we've liked that. I think although she's not on the panel, I've had a comment from Penny Shimmin. I mean, I'll just read it out because I think it's relevant to what you've just said, Michelle. So Penny says, fully appreciate the kind of responses she's hearing, but would want to emphasise that not all VCSE organisations and voluntary sector here involved in this field are micro or transient. Okay, so her own organisation is quite large and not at all transient. And like the speakers, we're working on how the benefits of access to green, open, and blue space are activated at community level. In our case, it includes coordinating with what is available at a micro-organisation level locally, or it's a bit like the point I've just made on the LMPs, and initiating new groups and activities to address the barriers that people experience. And she says she wants to endorse that not all participants come through social prescribing. So I think that's, I think there are good points there. And if we do a short account of the meeting at all, perhaps we can take Penny's comment there, because that might lead us on to the kind of meeting we should have next.
Yeah, I think just to echo Penny's point, she's absolutely right. There are large and small and medium organisations that have been operating for a number of years, doing a fantastic job. And when you were talking, Dan, I was just thinking about, a number of years ago, I came across something called the Natural Health Service, which probably people at the webinar today might have heard of, where there's a consortia of different groups that come together to enable that network to be formalised, so that you can get that buy-in from multiple organisations, and you can get that pooling of outcome measures, you can get that sort of combined collective collaboration that helps to maybe support the micro-organisations through the larger ones. So yeah, if there ever is another debate, I'd be really interested to look at how that Natural Health Service could be expanded and developed, and particularly as the results from Becca's work might come through.
Okay, fine. Thank you, Michelle. That's very helpful. Becca, do you want to say anything around Penny's points at all?
Yeah, I will. I'll just jump in. The government's new test and learn sites around social prescribing is partly about that. It's about how do we put in place the systems which enable all the whole sort of spectrum of providers, of the green activity providers, whether they're little micro groups through to well-established large national scale organisations such as the Wildlife Trust. How do you take out some of those barrier factors, such as the competitive need for funding, which drives an interest in novelty and not in funding the basic infrastructure of these things? How do we get rid of some of those real challenges to the system and put in place different systems which enable, you know, the demand to talk to people who are doing the supply, don't push out the little groups, keep those local groups who know what's needed in the local area and so on. So I think, going back to Tony's question, the infrastructure is absolutely fundamental to this, and it's both the infrastructure of green social prescribing and the use of the environment to promote health. But that's nested within green infrastructures as well, systems of green infrastructure. So ensuring that there are the spaces which are most effective to be used within place. And, you know, the way our land ownership works in the UK makes it really difficult to do that and understand who owns spaces and how you can use it, and what are the levers and tools that you can use to open up those spaces where they're needed for different groups. But then you also think about the nests of, you know, the wider social infrastructure. So is there a bus that goes between the community of need to the site where these green social prescribing activities have been run? at adequate times? Is there an adequate childcare system which enables mothers with poor mental health to go and access these kind of systems, activities? So, we're talking about multiple layers of really complex infrastructures, which sort of all need to slot into place to enable green social prescribing to work equitably, particularly, and effectively. So, it sounds like such a simple thing as you go to the doctor, get your referral out, you go to the activity. But actually, when you understand trying to understand what's going on all around it, it's so complex and so many little bits need to be in place. That I think that point about how we think about these systems quite differently and how we go about making decisions and share these outcomes needs to be addressed to make sure that something simple like taking people with poor mental health out into the natural environment can be a beneficial thing to do.
Thanks, Becca. And I think from organisations like Penny's down in Sussex, and then there must be others in other parts of the country. They are potentially, I think, quite valuable in this kind of area, because they are dealing on a day-to-day basis, not just in the area we're talking about today, but in many other areas. They're dealing with these kinds of issues that you mentioned, Becca and Michelle. They know what is going on at that kind of level and are often relating to a number of other organisations. So they're kind of a cog, I feel, in the process that we haven't perhaps made as much use of as we could. So I think maybe we'll continue this discussion in another meeting to see if we can draw out the experience and the lessons that are coming through there for how to make this thing work, for particularly perhaps for people who are less well placed just to take up information from the social prescribing thing. And as Michelle said, she's mentioned the way in which some of this organisational infrastructure can work with the local green infrastructure, etc. And in terms of the green infrastructure, of course, wouldn't it be good if we actually knew where it all was and what was accessible? In terms of these land ownership things and whether we could all have it mapped properly. Tony knows I've talked to him about this before, and there are some projects trying to tackle this, and even Ordnance Survey might tackle it to help us with these green infrastructure things. So I think perhaps on that note, I should start to say thank you for people so that we don't overrun. Thank you for everybody who attended today. Virtually everybody who linked up has stayed right to the very end, so that's always a very good sign for the organisers to see, and the panelists. And thank the panelists. Hugh's had to go, but thanks Michelle and Becca. Sorry you had your problems and things of that kind. Paula, thank you for doing introductions for us, and I hope you feel that this is something under the broad Natural Capital Initiative that can continue to provide not only interest but some value about how practically we can go forward. And if there are, I think there are some policy people and some influencing people on at the meeting today, and if they would like to give us any thoughts about how they could see some of these problems being taken forward, or want to engage with us in our further discussions, please do let Laura Bellingham at RSP know, and we'll see what we can do next time round to involve some of the funders and decision makers. I think that'll be a good thing to do. So with that, I'm going to close the meeting, unless Paula, you want to say a final word or two?
No, just a big thank you to you, Dan, as well as Becca and Michelle and Hugh on the panel. It's been a really exciting and interesting debate, and yeah, we would be really interested in ideas of taking some of the things that were proposed forwards in future debates. So yeah, please get in touch with either myself or Laura or Alison, or via our website, which is just at naturalcapitalinitiative.org.uk, and hopefully we'll see you again in the future at future debates. So thanks from us.
Okay, and thank you to everybody who attended and for your questions and your comments. I hope I managed to reflect your views accurately. So thank you very much, and we'll look forward to being able to meet in person at an appropriate time, not at a rushed time, but at an appropriate time. Okay, so with that, I'll say thank you to everybody, and we'll close the meeting. I think, Harriet, you will do that for us. Thanks, everybody. Thank you, Alison. Thank you. Everybody saying thank you. Thank you. Bye. Bye, everybody. Thank you for your time today. Hope you found it interesting and useful.